Welcome to the new EAU podcast series, How to Prevent Anxiety in Children Undergoing Urological Procedures. In this first episode, we are joined by Dr. Beatriz Bañuelos Marco and Dr. Michele Gnech. Together, they will discuss basic principles of preventing anxiety and the impact of urological procedures. Join us as we embark on this informative journey.
Hello and welcome. I'm Michele Gnech, pediatric urologist from Milan, Italy, and I'm joined by my colleague Beatriz Bañuelos.
Hi, Michele. To the rest of the people, I am Beatriz Bañuelos and I am working in Madrid, Spain. Today we are setting the foundation. We will explore the basic principles of preventive anxiety and how we as clinicians can begin making a difference from the very first encounter. Michele, let's start with the big question. Why is preoperative anxiety such a critical issue in pediatric urology?
Because it is incredibly common and it is far more than just a passing emotion. Preoperative anxiety can lead to measurable clinical consequences such as emergence delirium, increased postoperative pain score, behavioral change after discharge, and even impaired allying and reduced compliance with follow-up.
I agree, Michele, and I will add that the causes are multifactorial. Age is obviously important, but so are previous medical experiences, the child's temperament, parental stress levels, and how we structure the hospital environment. Urological procedures often involve genital examinations, catheterization, and anesthesia, all of which are inherently stressful, even for adults. This is especially important in children, which are already aware of their body, and for youngsters or adolescents, but not only. Children, even if not understanding completely or aware of the intimate nature of their genitals, can experience stress in a subconscious way, which is even more difficult to manage posteriorly. Therefore, all the measures that can be taken to avoid it matter.
On that note, I think it easy to underestimate how invasive even a simple diagnostic procedure can feel to a child. We are often dealing with the embarrassment, fear of pain, and separation from parent or caregiver.
Exactly. As I commented before, their understanding of what is happening is limited and varies widely with age, as well as the impact that this situation has in the child or teenager posteriorly. A toddler who can fully grasp the context may feel confused and betrayed, whereas a teenager might be scared or unwilling to show it or reluctant.
That's why preparation is everything. It is important to give children predictability, context, and some degree of control. For example, even knowing what a mask looks like or what to expect when a needle is placed can dramatically reduce anxiety.
So let's now talk about caregivers. The role is clearly crucial, but it's a double-edged sword, isn't it? Like you said before, explaining the child what to expect when a needle is placed reduces anxiety, but sometimes the caregiver anxiety to the procedure is the main sources of distress in this situation. Don't you agree?
Absolutely. A calm, well-prepared caregiver can be the most effective tool we have to reduce a child's anxiety. But if a caregiver is visibly stressed or untrained, is how to offer reassurance, it can have the opposite effect. Sometimes the caregiver had a previous experience as a patient which generated this distress. Knowing the background of these parents or caregiver and their preparation towards medical examination or procedure is fundamental to create the best possible environment.
Indeed. So not only do we need to know the parents' context and condition, but we might need to offer them support and strategies, guide them, and even provide training or orientation. A child isn't just a patient in isolation. They bring with them an entire emotional ecosystem from home. You might have a family where one of the parents suffers him or herself a medical condition. Even it's not infrequent that parents from children with urological conditions were also patients as they were children themselves. Some of them are well prepared, some of them are also dragging their own psychological issues, and even it could happen that they are too tough or they pretend to be too tough because of that and underestimate the impact on their own child.
Beatrice, speaking of that, there are patients with special need, for example. Do you agree that all of these becomes even more important for these children, such as those with autism, intellectual disabilities, or sensory processing issue?
Of course, Michelle, I truly agree. These children often face additional stressors. They might have difficulty with communication, hypersensibility to light, sounds, smells, or simply just don't understand what is happening.
Exactly. Their care must be as tailored as possible, both in terms of the environment and communication style. That might mean using visual support, scheduling the appointment, and quieter time or involving caregiver more closely.
I do agree. We need to anticipate triggers, noisy environments, abrupt transitions, unfamiliar faces. The fewer surprises, the better. Also, these patients will need more time in the consult. So rushing through the procedures or the examination, it's a no-go. We need to consider in this group of patients with special needs also the chronic sick children, such as transplanted children, spina bifida, etc. Because some of these patients, for example, those undergoing intermittent clean catheterization, sometimes benefit from other children of their own age showing them how to do it, or answering some of their doubts, or just seeing other children performing the same instrumentation that they are going through. I also have a very lovely experience with two boys around 12 years old, where both parent and children meet in the consult to talk about the catheterization, and it was really worth doing it. It took a lot of time, but it was worth it for both of them.
Beatrice, let's take a step back. In your opinion, beyond individual intervention, what structural change can hospital make to reduce anxiety?
Well, that's a great deal. There is actually a lot we can do, starting with reducing unnecessary fasting times, designing a child-friendly waiting areas, ensuring that staff receive training in pediatric communication techniques. And there is a point very important we need to be aware of. It's the cultural or society background of the children, because we are now having children coming from different origins, beliefs, and these need to be considered and respected. Sometimes this cultural barrier creates a much more difficult environment than the children fear per se.
We really need to reflect deeply on this simple but powerful action that we can implement. Knowing and addressing different contexts is essential to approach this topic properly, and this kind of training or education should be provided in the medical education, starting back from medical school. So, Beatrix, to sum up, I think that preventing anxiety is not about a single intervention. It is a mindset and integrated approach involving the child, the family, and the hospital team. And it is all start before the anesthetic process.
Exactly. Sometimes this starts already when we introduce ourselves. We need to recognize that this is not optional. Emotional safety is part of a quality care. In our next episode, we will explore non-pharmacological and pharmacological interventions, how they work, when to use them, and how to tailor them to each child.
Thanks for listening. We hope you found this episode useful.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.